Hey everyone, it's Adam Farkas. Welcome to another ODwire webinar. Thanks for coming out tonight. Tonight's topic is mastering scleral lenses with OCT and topography. And it's kind of funny, I remember when I was a young boy as a contact lens tech in my dad's office back in the 80s. So we're going back a long time now, right? And I remember his practice was especially contact lens practice, right? That's all he did. He had almost no scleral patients, at least in my memory. Thinking back, right? I remember asking him about it back then even, and he went through why and how difficult it was to actually fit the patient and use moldite, and it was a whole to-do, and actually, the process of actually fitting a patient would take a long time, wouldn't be the most successful, so that's why these other lenses were more popular. So I filed that away in the back of my brain, but over the last, say, 15 to 20 years, sclerals have become incredibly popular, and that's for a variety of reasons, right? The indications for using them have been expanding, but most importantly, the technology has improved. So fits are becoming more successful, faster, with fewer remakes, and anybody can, if they have the desire, can learn how to do this. It's gone from sort of a black art to real science. And I think that's what we're going to talk about here tonight, how you can implement sort of cutting edge science to really help you fit sclerals properly. But obviously to do that, we need experts. You don't need me. So we have two experts here with us tonight. So Millie Brujic, who scarcely needs an introduction here. He's done more webinars here than I can count. So he's a partner in Premier Vision Group, a successful 4-location optometric practice in Ohio. He obviously practices full scope. He's been active at all levels of organized optometry. Certainly you've read many of his publications, as he's given thousands of lectures and written hundreds of articles over the past decade. So it's really great to have him here to give us a perspective from the clinician's perspective of how to actually go about fitting these lenses. And we also have Jeff Sonsino with us. And again, Jeff scarcely needs an introduction. He's the past chair of the contact lens and cornea section of the AOA. He's the founder and CMO of Iris, and he's been a tireless advocate both for patients and for doctors in Washington, D.C. So he's doing a lot of the work that many people don't have the stomach for. So Jeff, kudos to you for taking it on. And so with that, let me actually turn control over to our speakers.
Great, Adam, thank you so much, and I appreciate that. And this is the perfect introduction to the discussion because, Adam, you set it up perfectly. So I graduated 23 years ago, and at that time, scleral lenses weren't even a real kind of implementable thing. And over the last 20 years, we've really seen them evolve. And it really involves two things. One, the technologies that we're utilizing in the lenses, and also, in addition to that, the way that we're metricizing the lens on the surface of the eye. And that's what we're going to be talking about this evening, really harnessing the power of anterior segment OCT and what it can provide us in terms of that additional information that's giving us precision-based fitting processes within our practice. Saying that though, both Jeff and I have the Solix by Visionix in our offices, and we're going to be focusing 98% of the efforts on anterior segment, but it is important to understand that this is a full scope OCT. It offers full range anterior segment that we're going to be talking about, but it also offers full range retinal imaging, not only traditional OCT, but also angiography. You can also do external color and infrared photography that you'll see here in a few moments. There's angioanalytics, there's angio wellness, and there's also the glaucoma scans that provide with and without angio capabilities. So you're really looking at a system that provides you with essentially everything that you would need in the optometric practice. But we're here this evening to talk about its role in scleral lenses. And I remember in 2006 when we got our first OCT and it measured, and it had the small little end that you put on the front of the instrument to measure pachymetry scans or corneal thickness scans. And I asked the rep, I said, what would I need this for? And he said, well, I think people are using it to measure angles. I said, okay. And I think people are using it to measure corneal thickness. I said, oh, okay. That makes sense. And little did I realize that glaucoma and angle scans were going to be just the minority of what we were using this instrument for 20 years later. What you're looking at here, and just to calibrate everybody, because Some people online tonight have the Solix, so we'll understand these scans, and some people do not have a Solix. So I want to go over the basis around what you're looking at here. So on the top left, and you'll see a lot of these scans have similarities, but on the top left, you can actually see what's physically being scanned here, and that's the front of the eye. And all of these radial scans right here represent different radii of the scans that are being created. And what you're looking at is a 10 mm total scan of the cornea. This is the cross section that you're looking at right here that's being denoted by this small little arrow right here on an angle. And what you can see on the bottom left that I'm showing you here with my arrow, that's the total corneal thickness. And on the bottom right is what's being represented as the epithelial thickness. And what you can see here is there's a scale beside the total corneal thickness, and on the right-hand side, there's a scale that denotes the epithelial thickness. And what you can see in these individuals or these patients is we oftentimes forget that keratoconus in and of itself is a corneal thinning condition that manifests as ectasia, but ultimately, this is a corneal thinning condition that results in ectasia. And you can see that here where the cornea is thinning, and that's denoted by the darker blue colors. But when you look at the right-hand side of the screen, you can also see centrally that as the cone becomes more severe, you'll actually start to see epithelial thinning as well too, typically where the thinner region of the total corneal thickness resides. And in some of these individuals, you'll also see a donut of thicker corneal epithelium surrounding that region centrally that's of the thinner corneal epithelium. Now this sets the basis, but you can also see too that you can even isolate different parts of the cornea. On this scan, again, you can see exactly where we're looking at this cornea through. It's a vertical scan. And on the top right, you can actually see the cut through that vertical section of the cornea. And on the bottom left, you can see what the total corneal thickness is. But on the bottom right, you can actually see what the stromal map actually looks like. So instead of isolating the epithelial thickness, we're actually isolating the stroma. And what you can see here is that in this individual, it's actually more pronounced when you look at the stromal thickness and how it is thinning in this region where we typically tend to see the cone. Now, this is where the technology just starts to get kind of interesting, because this is where we do one of two things. It helps us in the diagnosis, and it also helps us in monitoring these patients over time. Jeff, how are you utilizing these scans in your practice, not only in terms of identifying the disease, but also monitoring it over time?
Every single year when we see a keratocone, and to preface this, I'll just give you a little bit more about my background. My practice is 100% complex contact lens, so I don't see patients that don't have some kind of corneal pathology. I do about 25 patients a day, and I'm in practice 3.5 days a week. And so we do a decent volume of keratoconus in my practice. And every single year when I see a keratoconic patient, we're doing pachymetry on that patient, and we're checking to see if there's any progression. And one of the things I love about this system that we're using is you can see a map of every single year that you see the patient. And so it will show you every pachymetry that you take, and so you can really get an idea of if there is progression or not.
Jeff, one of the things too, and I love that you point that out, because it does give you the baseline, and it also gives you what that future will look like in that individual and whether or not we're seeing change. It also denotes, and you can see it right here on the total corneal thickness. And Jeff, can you confirm that you can see my cursor on the screen right now?
Cannot.
Okay.
But if you go to the little, there should be like a little laser somewhere.
So there's a small, tiny little asterisk on the bottom left scan. And that small, tiny little blue star asterisk denotes the thinnest part of the cornea. And it actually shows you over here on the left-hand side of the screen what that minimum thickness reading physically is. So again, You go over to the left and the second line down says min, and that's actually the measurement of the minimum part of that cornea. This is important because when we're classifying the level of keratoconus for various vision plans, they make us, or they require us to use this as one of the guides on whether or not we're dealing with a early keratoconic patient or a more severe patient. One of the things that I love doing for patients, in particular when we haven't seen them in our office, so if it's a new patient to the practice or if they're being referred in for a specialty fit, I love this anterior segment imaging capability, because one of the things we do on every patient is we do corneal map, which encompasses not only the anterior segment pachymetry scan, but also topography and tomography of the front and back surface of that cornea that we're going to talk about in just a few moments. But it also has the ability to show us an anterior segment image of that eye. And what you can see in this individual is that you have a clear media that you're looking through. So we should, barring a healthy posterior segment, we should get very, very good vision from that patient if we fit them appropriately. This individual's chief complaint was, I want to see better out of my left eye than I'm currently seeing out of my current scleral lens. And we know that there's going to be limitations just based on nothing more than the corneal clouding that we're physically seeing in this individual. And I know this with this technology before I even walk into the exam room with this patient.
Hey, Emil, can you go back to that for just a sec? So I have this conversation with patients all the time, you know, when they ask, what am I going to be capable of seeing before we even put on a scleral lens? And the way I describe it is I say, look, you know, you have a corneal scar, and that's going to represent a speed limit that we're going to butt up against for visual acuity. And we're going to take it right up to that speed limit and take it as far as we can, but that is going to limit our vision. And that's the way I describe it.
Jeff, I love that description, and I love the fact that we have the ability to share this imaging with our patients so that they can understand this a little bit better as well, too. So as we start kind of thinking about the other things that we can do, and this is all done on the OCT, you can actually take meibography on the OCT as well, too. And the meibography, and simply the way it works is it's an infrared image. And infrared imaging, all it does is it takes tissues that are more metabolically active, and it shows them to us as whiter regions or areas, which is part of the reason why when we take meibography of the upper and lower palpebral conjunctival surface, we will see where meibomian glands are more metabolically active, and they'll show up as white. And you can see in this individual that they have shortened glands inferiorly, and they have some irregular gland length superiorly. Why this is important is we all know that a contact lens wearer, and especially contact lens wearer, doesn't live in isolation of just simply a cornea that we're fitting. It's an ocular surface that we're fitting, and we need to be well up to speed on what's happening with that ocular surface so that we know how to guide that individual. And Jeff, this is one of the tools that we have to identify ocular surface disease and risk for it. How important do you think that is with our specialty lens wearers?
I mean, you basically cannot be prescribing scleral lenses unless you are also running a dry eye center in your practice. I mean, the two go hand in hand. The number one problem we see with scleral lens patients is dryness. And the second I see that, the second I see the front surface of the lens, you can actually see between blinks, the front surface just kind of evaporates away. Immediately when I see that, I'll take a video of that in the slit lamp, and then we'll run over to the OCT. We'll do meibography and get an idea of what the lay of the land is for the meibomian glands. And that immediately starts the discussion of, okay, you know, you're going to get a great result, but we have to be addressing the dryness at the same time. And if you say that ahead of time, before it becomes a problem, then you're the hero. If you let it happen to you and you get the dryness on the front surface and you hadn't said anything about meibomian gland dysfunction, then you as the practitioner are now the zero.
Yep. So you're helping identify it initially. It's the patient's challenges with their ocular surface they have that you're helping them with. I love that strategy, Jeff. You know, we understand that keratoconus is a disruptive condition. And again, we always talk about it as this ectatic condition, but the reality is it's a corneal thinning condition that results in ectasia. And this is just another way to look at the data that we showed you in the previous slides, where you actually have total corneal thickness for the right and the left eye at the top. And you can see the scales respectively on the right and left-hand side. And then you have the epithelial thickness at the bottom, and you can see exactly where the early cone changes are, that early thinning is inferiorly in the total corneal map, but also in the epithelial map. But this is where it gets really, really interesting, because in addition to measuring that corneal map, you also get topography findings as well too. Now I want to decode this as well for you too, because this gets very, very busy very quickly. And I'm going to kind of give you a map on what you're looking at here. So to give you the lay of the land, on the left-hand side, what you're looking at is, so top left, you're looking at what's equivalent to the anterior tangential scan on the OCT. So this is the anterior surface of the cornea and what that looks like. On the bottom left, you're actually looking at the posterior surface of the cornea. In the middle column at the top, you're looking at the epithelial thickness. So again, you can see that there's some irregularity in this individual, where the green region represents some thinning areas. And then the bottom center is the true net power, which ultimately highlights any irregularities in terms of the power delivery to the ocular system. On the far right, you have something referred to as anterior elevation BFS, and in the bottom right, which is one of the most valuable scans, is the posterior elevation BFS. BFS is an acronym that stands for Best Fit Sphere. And what this is describing is how much does the posterior surface of the cornea vary from what is the best fit sphere on both the posterior surface, which you can see in the bottom right, or the anterior surface, which is the top right. And what we know is that keratoconus, some of the earliest signs of keratoconus are actually seen as this deviation from best fit sphere on the posterior surface of the cornea. And you'll see some examples here where when we look at about 15 to 20, that's like the early indications that something is not what we would expect it to be in terms of its best fit sphere deviation or elevation. So again, this is just representative of a highly keratoconic patient and what you would see in this individual. And this is the patient's other eye. So again, you can see when you're looking at the left-hand side, you're looking at the anterior surface and the posterior surface. You're looking at the epithelial thickness and the true power net. And in the bottom right, you're actually looking at the elevation from the posterior best fit sphere elevation. And again, you can see the red region at the bottom of that map showing how much it's deviated from where that best fit sphere would be. So one of the beautiful things about this as well too is as you're scanning these patients, you can determine what's normal from abnormal. So this is an example of an individual who I recently saw. It's a 6th diopter astigmatic patient. It's with the rule, but with that level of astigmatism, you're always wondering if there's any type of ectasia that's associated with it. So these are the pachymetry scans. And fortunately, just from these pachymetry scans, nothing really stands out as concerning or risk factor for keratoconus, other than that high level of astigmatism. And when we look at the topographies, essentially, and when we look at the anterior surface, that's the top left, you can see it has that classic dumbbell appearance. There's a little bit of asymmetry there, but it looks pretty symmetrical for the most part. And when you look at the bottom right image, the deviation or the elevation from the best fit sphere, you can see it follows a very, very classic high cylinder patient pattern where you're not seeing that best fit sphere elevation deviation in the center of the cornea or just in the inferior portion. You're seeing it equally displaced in the inferior and superior portion. And this gives you guidance and security that you're dealing with a normal cornea in this individual. And again, in the other eye, it's virtually the exact same thing for that individual or that patient. And what's also interesting with these patients too is that we've learned a lot over the years, first going from the 6mm radial scans to now the 10mm radial scans on the cornea. But sometimes the answer to the patient's reduced best corrected visual acuity lies in the epithelial thickness map. And this is something that we look at very, very carefully for those patients where we can't get them to 20/20. There's something that's limiting them from getting there, and we're not seeing the answer in standard topographies, and we're not seeing the answer in total corneal thickness maps. Oftentimes it resides in this bottom right-hand scan, which is the epithelial thickness map. So again, you can see the variation that exists here with all the various colors. We expect that coloring to be much more consistent. And whenever you see a variation in that color pattern, that really gives you indication that something else is occurring. This is a post-LASIK patient where you can see the anterior tangential scan in the top left looks, relatively speaking, pretty normal. But it's the epithelial thickness map that really gives us indication of what's causing the reduced best corrected visual acuity. This is another example of an individual who has a small little scar just inferior to the patient's pupil. And when you do a topography, it looks relatively normal, but when you do the corneal pachymetry scan, you can see on the bottom right-hand side, which is representative of the epithelial thickness map, you can see the irregularity that exists there. This patient's best corrected visual acuity is 20/40. And when you fit them with the scleral lens, so this patient we got down to 20/15. And when you look at the cross-section of the actual OCT scan up here to the top left of it, you can actually see where that scar is located. Again, just left of the center of that top image. Again, to the very anterior surface, just beneath the epithelium. So again, it gives us indications of what's going on with these individuals or with these patients. So there's a lot that we can look at here, and we're now even leveraging epithelial thickness maps, again, which is the bottom right-hand scan, with our orthokeratology patients. So you can see where the epithelium is actually being flattened and where it's being pushed out. And you can see in this instance, you're actually having the lens decentered inferior nasally on this individual's eye, and you can see it by this cuff of larger epithelial thickness in this bottom right-hand scan. But we now do this in addition to topography scans on this patient, because with the Solix, you get all of this information at the exact same time with simply one scan. So for the purposes of time, what we're going to do is we're actually going to jump into the scleral lens section, because what we're talking about right now is really identifying those things that help us monitor the cornea over time, whether it be the disease itself, whether it be identifying the disease, or whether it be looking at the orthokeratology and what that does to the epithelial thickening. But when we're thinking about these types of tools, yeah.
One thing to point out that I think is really important about the topographical map that you get generated from the OCT is that it's a true elevation map. So this does not rely on Placido disc. And the reason that's important is that in Placido disc, you can get fooled, right? If the patient has a dry eye, it can look like an irregular astigmatism, whereas it's really just dry eye. And you can kind of sort those patients out and make sure that you're doing the right thing for the patient.
Jeff, I'm so glad you brought that up. That's such a key point, and it also brings up the point that a lot of times the technicians, when they're doing traditional topographies, they're actually masking some of that dry eye because they're putting an artificial tear on the eye so that they can get those good Placido rings. This is, as you said, Placido ring independent. So that's one of the strong suits with this, is that you're going to get that same image the same time every single time you take that scan. I'm glad you brought that up, Jeff. So when we're thinking about scleral lenses, there's three big places that we think about. That's the central corneal clearance, the limbal clearance, and the landing zone. And we're going to show you what it looks like right now when you're leveraging the power of the OCT to actually help you guide all of those measurements. Because at this point, the only thing I'm using the slit lamp for is to assess whether or not there is clearance when we first put the diagnostic lens on eye. I presented this poster several years ago at Global Specialty Lens Symposium that actually showed me and compared my slit lamp estimates to what we were actually measuring at the OCT. And I was absolutely way off. And it just showed me that we need to be as precision-based as possible. And the OCT gives us the ability to do that. So Jeff, give us guidance on what you're using and how you're using this during the scleral lens fitting process.
Right, so now I'm just going to take you through exactly what scans we're taking at every single visit when we see scleral lens patients. And the one that you'll see on the left side of the screen here is kind of a standard. It's a line scan, really just through the dead center of the cornea. And with a horizontal scan, you're looking for a few things. Number one, what's the central vault? But number two, is that lens centered or tilting on the eye, or is it decentered nasally or temporally? And then to the right of the screen, you'll see we also take a vertical line scan to look to see if it's vertically decentered. As most of you probably know, the number one problem that most of us have with the fit of a scleral lens is inferotemporal decentration. And so this will let you know how much decentration you have. And especially like in this case where there's an intact segment in the cornea and the cornea is elevated inferiorly through that segment, you want to know how close you're coming to, you know, the scleral lens to that plastic within the cornea. Because the last thing you want is plastic sandwiching tissue, sandwiching plastic. That's a recipe for disaster. Next slide,
Jeff,
please.
what's a typical target that you're looking at for central clearance?
Great question. So, you know, this target was laid out in a series of papers that Longy Michaud published back in 2012, where they were looking at the amount of oxygen that reaches the cornea through a scleral lens. And what those papers established for us in the industry is that you really should be shooting for 200 microns of vault. Now, the paper didn't say when you should get that 200 microns of vault, whether it's, you know, right when you put that lens on, or if that's at the end of the day. But basically what the papers told us is that the closer you get to 200 microns of vault throughout the wear of this lens, the more oxygen you're going to get to the cornea. And further, in a second paper, what they showed is that if you go up to 400 microns of vault, you reduce the amount of oxygen getting to the cornea by 30%. And that's a big deal. So what that tells us is, gone are the days where you can just kind of like eyeball how much, you know, vault you have using the slit beam estimation technique. We really have to be fitting scleral lenses with precision. And really what we're shooting for is that 200 micron level of vault. So the first two images that we take are line scans through the center of the lens, one horizontal and one vertical. But then we're taking line scans at the haptics, or you know, something that shows us the limbal clearance, like Mile showed us in a few slides ago, and the haptic alignment. And we're doing that in 4 quadrants at least. And you can see I kind of highlighted where the line scan is on the in-face image. So each of these images has the OCT image above, and then it has an en-face image, which is basically just a straight ahead image of where you are on the eye. And that helps to figure out in each major meridian of the scleral lens, because most of us should be fitting toric haptics at this point. What we know also from the research is that 95% of eyes out there call for toric haptic lenses. And so if you're fitting a toric haptic lens, that means there's 2 meridians. There's a horizontal meridian and a vertical meridian. And so when we're taking the line scans, we're looking to try to image the major meridians of the lens. And I think something that's really important to point out here is that you don't just have that patient looking straight ahead in primary gaze and then take each quadrant of the lens. You actually have the patient look opposite to the side that you're trying to image. If you'll go back one, please, Mil. Basically what we're doing is we have the patient look in the opposite direction of where we want to image. And by doing that, you'll see the line scans that we're taking here. The line scan is basically perpendicular to the infrared beam. And that's how you get the best quality image that shows the least warpage of the image. Next slide.
So Jeff, you'll sometimes even too then tilt where you're actually measuring depending on where those major meridians are, correct?
There are some times that I will take not just those 6 images that I showed you, but we will take 4 more that are in the major meridians if those major meridians are not at 3 and 9 and 6 and 12 or close to it. Because we want to find where the flattest part of the haptic is and where the steepest part of the haptic is. And those are really what we're interested in. But then if you really want to get fancy and you want to get creative and really get some interesting shots, there is a full field image that you can take with the Solix, which shows you limbus to limbus how this lens is sitting. And I love this example that I picked out because it shows you really a great idea of what decentration of a lens looks like. On the image to the left, that's a horizontal slice, right? And this is a left eye. And so to the left of your screen is nasal, to the right of that image is temporal, and you can really see how this lens is temporally decentered. But then again, we flip this around 90 degrees, and you can see in the image to the right, that's a vertical slice. And now look how inferiorly decentered this lens is. And so if you see something like this, you know you have to make some pretty radical changes to the scleral lens. Next slide.
Jeff, one of the things I love about this this image too is when you look to the bottom of each of these images, you see a blue circle and a smaller green circle. Those are intended and they're manipulable, so you can actually measure the horizontal visible iris diameter without actually guessing it. And you can also measure the pupil size on that patient as well too, which is for some people more important than other individuals. Now, Jeff, I want to do a deeper dive into one of the scans that you were talking about, because 2 things are important with the Solix. So if you have it, make sure that you're having patients turn in the different directions where, like Jeff described. But it's also important to identify the limbus, because the reason why we do these scans is to make sure we're clearing the limbus and make sure we're landing the lens appropriately. So one of the trickiest things with these scans is to identify the limbal region. Now, when I kind of introduce 2 regions, you can see very easily the white arrow is pointing to corneal epithelium, and the blue arrow is pointing to conjunctival epithelium. And you can see, like, when you compare those 2, they look very, very different. But at some point in between those 2, you're going to get the transition from cornea to sclera with overlying conjunctiva. So the question becomes, where does that happen? Well, there are a few landmarks that we can look for. The first one I've just identified, you can actually see when you look really closely with that one arrow that I just introduced from the superior region, where the epithelium from the cornea actually transitions and changes into the conjunctival epithelium. And you can see how it looks different to the right side of that arrow than it does to the left side of the arrow. But there's another anatomical marker, and I'm going to draw it in here. It's this small little angle of tissue that comes from the sclera into the cornea. And I'm going to take it away here just for a second, and then I'm going to reintroduce that. This really gives us guidance on where to look initially so that we can start doing a deeper dive and identifying the limbal region. And what we've just identified right there is where that limbal region is. So again, remember some of those anatomical landmarks to help guide where you're viewing that limbal region, because we have to make sure that when we're fitting scleral lenses, we are in fact clearing it. Jeff, what's the guidance on how much or how little we should be clearing the limbus?
This is one of those kind of amorphous questions, which there's no great answer to. And the way that I describe this to students and to my associates is that you just have to kind of extrapolate in your mind, is this lens that you put on and you image right when you insert that lens, is this lens by the end of the day going to touch the limbus? And if you feel like as that lens settles, it's going to hit the limbus, you have to make changes.
So here's the cool thing about the technologies that we're fitting nowadays is they've just changed so much. And most of the contemporary scleral lens companies have actually created limbal lift zones or regions that are lifting up away from the limbal region in a very kind of strategic way. So what I've highlighted here with the first yellow arrow is the landing zone of the lens. You can actually see there's a reverse geometry curve that occurs that lifts the lens away from the surface of the eye. But if they didn't change the trajectory of that, the lens would just have massive amounts of central clearance. So what a lot of the contemporary scleral companies have done is they've actually added a secondary curve or a secondary reverse curve to control that lift over the total cornea. And what this gives us as a clinician is the ease and purposeful fitting to clear the limbus 360 degrees, which you can see exactly in this scan that is in fact happening in this patient or this individual. And that's exactly what we want in these individuals. We want that limbus to be physically cleared. Now, when you're looking at the landing zone on these patients, there are several things that I want you to keep in mind. You know, when we look at this scan right here, for example, and you can see this is the left eye, so the patient's looking to the one side and we're getting the scan. But when they do that, the OCT's measuring the image partially through a lens, which is plastic, and partially not through a lens, which is not plastic. So what we'll inevitably get is an image shift that occurs right at the edge of where the lens ends and the other tissue begins. So I want to pull this one arrow away. So when you first look at the outside edge of this lens, it almost looks like the lens is digging into the tissue, when in actuality, there's just simply a subtle image shift that's occurring that's making it look like that lens is digging into the tissue, when in fact it isn't. So be cognizant of that. One of the things that we do want to pay attention to is where I put the second arrow. As we kind of go back into the landing zone, so the more proximal portions of the landing zone, not the distal portions, which are on the right-hand side of the screen, but the more proximal portions, you can see how the toe is subtly, which is the most distal portion, it is subtly resting more weight on itself than in the heel part, or the more proximal portion. And you can see this through this subtle little lift that's occurring in the landing zone right here. So those are things that we need to be cognizant of. And this gives us indication that the toe on this lens, or the most distal portion of this, the most distal portion of this lens, will likely need to be lifted or elevated just a little bit. And this is another example of a situation where the most distal portion of the landing zone is just a little bit of what we would refer to as toe down, and the heel is just a little bit up. And we really want that consistent landing zone along the whole profile of the landing zone on a scleral lens when we're fitting it with a patient. So the way we would communicate that to the lab is whatever meridian we're looking at, we just want to bring the toe up just subtly in that patient. And this is what we're looking at when we're looking at more of an aligned fit. You can see that the trajectory of the landing zone very evenly distributes its weight all across the actual foot of that landing zone, with plenty of room for limbal clearance. Again, this is ideally what we're looking for in these individuals or patients. Now, Jeff, I'd love for you to go through the flow here and what you're doing with the flow.
So, you know, obviously, if I'm seeing 25 scleral lens patients a day, this is not something that I can do on my own. And so in my practice, we have a very tech-driven process. And the beauty about this technology is that it is so dang easy to use that my technician, who I've, you know, trained for one day, on the second day that they're with me in practice, they're able to run the OCT. It's very easy. And so when we have a new patient that comes in, if they arrive wearing scleral lenses, we have the tech take anterior segment OCT of the patient's lenses. We then do visual acuity with the lenses. The tech then removes the lenses. They take topography, pachymetry, retinal imaging, and do a refraction. And then they bring that information to me, and that's when I go in the room and discuss kind of the plan. And the beauty of this is that, you know, with a tech-driven process, it allows you to see many, many more patients in the interim. Now, if that is a follow-up, and we do this at every single follow-up or dispense of a scleral lens, we'll have the tech insert the lenses. The tech will do anterior segment OCT. They do wavefront aberrometry on top of the lens, and then the tech does an over-refraction. And I think the reason why this is important is that a lot of optometrists just don't want to invest a lot in their technicians. And the perfect example of why you should this was a great, you know, instance that happened to Steve Jobs. You know, one of Steve Jobs' lieutenants came to him and said, "Oh my God, Steve, we are training all of our people and they're going to be leaving us. They're going to be going to other companies. And what are we going to do about this?" And he just looked at his lieutenant and he said, "What are we going to do if we don't train them and they stay?" So I'd encourage you to really get your technicians, you know, doing the bulk of this work. That they're there to help you.
I love that quote, Jeff. Absolutely love it. This is one of the things that you'll run into when you're fitting these patients. This is some conjunctival prolapse that you'll see under here, but you're seeing adequate limbal clearance in this region right here. So in the presence of conjunctival prolapse, we simply monitor it and watch it over time to determine if there's any level of negative influence on it. Jeff, take us through a few things with respect to just some of the things that we need to be thinking about with respect to insurance companies and how we're utilizing these technologies.
Yeah, look, there's, you know, there's a whole world of what you need to be doing with your charting in order to be bulletproof when you're audited. Mile knows that I'm audited by every insurance I take every single year because of the numbers that we post. And so one of the things that OCT helps you do is stay pristine with your audits. You know, obviously your charting has to be pristine too. So anytime you do ancillary testing, whether that's topography, pachymetry, or anterior segment OCT, all of that ancillary testing must have an order, a date, a justification for the order, and an interpretation and report. And that has to be visible within your electronic medical record. And so you just come up with a script for that and you copy and paste it and modify it for each patient. But then if you are audited, what you want to do is you want to print every single test for which you billed. And so when I get audited on some of these patients, they may have 30 pages of testing because we're printing out every single OCT that we're doing. And what that shows the auditor is that you're not just billing for medically necessary lenses like out of the blue. There's a reason why, you know, you can justify the cost of these things, which is it's a significant cost to the insurance company. And when they get 30 pages of testing back on each audit, they're like, oh, okay, this doctor knows what they're doing. And so the Solix that we're talking about tonight has all these main tests. And as Mile said, you know, the pachymetry and the topography, that's done with one click. But each of those is printed out on a separate scan. And so you are able to bill for those things independently, even though it is the same button we're pressing. Next slide.
Let's finish it off with this case, bud, and then we'll take some questions.
I think it's a great idea. So just a real quick case showing you kind of how we do this in clinic. This is a 39-year-old white male with a history of PRK. He was coming in for his annual scleral lens exam. His complaints were redness, poor comfort, poor wetting with his current scleral lenses. In those lenses, he came in seeing 20/30 -2 in the right eye and 20/25 -2 in the left eye. When you look at the scan of the central cornea, whoever fit this person, it looked like it was a pretty good fit. You know, if you look real closely, you can see there's 213 microns of clearance horizontally and about that vertically. So this person at least knew a minimum of what they were doing, but you can tell by these OCTs that the person that fit them was just a real jackass, and they just didn't. No, I'm just kidding. This was actually my patient. So this was a former lens that we fit on this patient.
No, you're right. You're right. Then on the first description, Jeff, you were dead on.
So, look, our ideas about how to fit scleral lenses have evolved over time. And this is a patient that came in like 4 years later after being fit with these lenses. And if you look really closely at the horizontal images, and it's a little bit tough to see, but if you look at the image all the way to the right here, you can see that this lens is just slamming the heck out of the limbus. I mean, it's just, oh, now we can see your cursor, Emil. It's just slamming the heck out of the limbus. And that's why this patient is red. What you'll notice is as you get off of limbus in patients, they will have less redness and they will have greater comfort. And that's a lock. Let's go to the next slide.
Jeff, I just want to point out one quick thing here too. You can even see that a little bit on the other side horizontally, but when you look superiorly and inferiorly, there does seem to be a little bit more limbal clearance, and you'll find that because you oftentimes find that the horizontal visible iris diameter is slightly wider than the vertical visible iris diameter in a lot of these people, and the scleral lenses really accentuate that fact as well too.
So what is the main problem here? Obviously, we are on the limbus and we have to get off the limbus. And so we refit this patient. You can see the horizontal scan here. This is the trial lens that we put on the patient. And we have decent central clearance horizontally. Vertically, there was, ooh, this didn't come out well. Vertically, you see superiorly, there is a little bit of touch there. And you can see some inferior decentration. So that's something that we're going to have to clean up in this fit. We can go to the next slide. Ooh, it didn't go real well. But you know what? The only reason these are overlapped is because I overlaid the 4 haptic scans. But what you can see here is in these 4 haptic scans, there is plenty of limbal clearance in these images. And just because of that, the patient said immediately that the trial lenses were more comfortable than his previous lenses. Next slide.
Yeah, Jeff, you can really see that nasally and temporally as well too. Like there's just so much area right here and right here at the limbus. I love this second fit that you did.
Let's open it up to some questions, man.
Well, guys, I think we are. Yeah, let's open it up. And Adam, I think you've been collecting the questions throughout the discussion.
Indeed,
if anybody does want a virtual demo, again, as well.
Yeah, well, thank you guys for this. This has been, action-packed and very informative. So we do have some questions here, and we'll open it up and we'll see what we can do. So let's see. So first question. Oh, interesting. So one question here, and again, for either of you guys, you can just take it. Are you using the Solix exclusively now for monitoring keratoconus, or do you also use other instruments?
So Adam, I'll take that one first. From measuring the cornea, Adam, it is the only technology we're now using because of the advent of the topography and the anterior and posterior surface measurements. It's the only measurement that we're now using to monitor the cornea over time.
I'm kind of angry at Visionics for introducing that topographer because it caused me to buy another device before this came out. So I have like another topographer that I don't use anymore because now I just use the Solix. So I've got this thing collecting dust in my practice.
Good answer. A question here. Do you always take a full range AC and corneal line scan for all scleral lens assessments?
I'll take that one. The answer to that is no, I don't do it all times. Really, I'll take that image when I'm concerned about decentration to try to figure out exactly how much decentration that I have. But if you notice, like in that full that full range scan, the patient is looking in primary gaze. So you're going to want to take those individual images, those individual line scans of each of the major meridians of the haptics, in addition to doing the full range line scan.
Hey, Adam, and just from my perspective, I love taking that on a new fit because what that full range scan gives us is just a quick view of what the cornea actually looks like from the horizontal perspective. And you can get a full map of it, but sometimes it's difficult for patients to keep their eyes open that wide. But the thing I love about it is you can get a horizontal visible iris diameter measurement, and you can also get a pupil measurement as well too on those individuals. But the HVID is important because that plays a role into what initial lens diameter we'll select for that patient.
Right. Question here. So this is kind of a basic question, I guess, but you know, you guys can try to answer this. I'm surprised my dad didn't ask this actually, because the question is how what's the process like of actually creating one of these lenses these days, right? So gone are the days of slapping mold on someone's face, I would assume, and sending it off to a lab and seeing it 3 weeks later. So what's the actual process of getting a lens made?
Jeff, you want me to start?
Yeah, go ahead.
So Adam, we'll take, so we have a diagnostic set. And then what we'll do with that diagnostic set is we'll pick what we think is the best initial lens. We'll place the lens on the eye and then make sure that it's clearing the cornea. And as long as it's clearing the cornea, we take the 6 scans that Jeff was talking about, those central 2, and then ones in the 4 major meridians, showing or demonstrating the limbal region and the landing zone. And then what we do is we do an auto refraction over the lens, do a manual or manifest refraction over the lens, and then with all of that information, we'll have what the lab needs then to create the lens. So we'll take all of that information, determine where the lens needs to be manipulated to create that final lens for the patient, and then we'll put that order into the lab.
Got it. And question here, I guess this is a related question, question about remakes. So how frequently do you have to remake a lens, and what's the turnaround time usually when it happens?
To remake a scleral lens?
Yep.
It depends on the lab that you're working with. Every single lab has a little bit of a different time frame, but we're pretty good at getting our lenses within 7 to 10 days from when we order them. And then it depends on the patient. So we'll have some patients where the first lens we make for them is the final lens. Sometimes it takes 5 lenses to get the right lens, and then we have all the patients in between. So it just really depends on the patient. It really depends on the landmarks around the cornea that we're fitting, and it depends on how well we're conveying what we're seeing to the laboratories that are creating these lenses.
I'm going to take that question, I'm going to spin that around into what you tell the patient, right? So if you have a patient that comes in that's not familiar with the fitting process, like how you describe this to somebody. And I rely on a wonderful paper that Melissa Barnett published way back that showed that the average scleral lens takes 4 to 6 visits to perfect. And I'll tell the patient that. I say, look, you know, it's going to take us 4 to 6 visits to get this right the first year that we do this. But once we find the formula that works for you in subsequent years, it's going to be 1 or 2 visits as we just kind of modify what we already have created. And that immediately gets their mind right into, okay, this is going to take a number of visits. It's not like a soft lens where you just come in and you get fit and you're, you know, one and done. And when you do that, when you set the patient up with that expectation, then if you get it in sooner than 4 to 6 visits, then you're a genius, right? And then the patient is never angry with you if it does take 4 to 6 visits.
Right.
You're a hero, Jeff. And if it takes longer than 6 visits, you're 0.
So interesting question here. So we've been focusing on keratoconus, obviously, right, because this is a primary application of this lens. But have you seen this lens used for other indications in your own practices so far? Like I know that I've seen people try to make multifocals, right? Have you started sort of down this path with any other conditions?
Adam, there are several conditions that a new surface over the eye would benefit. Some of those are pellucid or any other ectasias that the patient may be experiencing, irregular corneas after LASIK or RK, any type of EBMD. These individuals oftentimes are floating around in our practices with reduced best corrected visual acuities. These individuals do remarkably well with these lenses. Those patients who may have had a previous infection, whether it be infectious or some other type of issue with the cornea that's now left them with the deformity, oftentimes these lenses will make those patients better. And certainly for the severe ocular surface disease patients, the graft versus the host disease, individuals with severe dry eye, they create this shell that retains moisture on the surface of the eye, and in doing so, oftentimes preserving the viability of the cornea for these individuals. So there are a lot of things that we could use these lenses for.
Great. All right, and it looks like we are just about at the end of our hour, but do you guys want to leave us with any sort of parting thoughts before we go?
Jeff?
I'll just say that I think a lot of optometrists are afraid to kind of venture into new territory when it comes to scleral lenses. You know, unless you graduated within the past, 3 or 4 years, none of us learned this in school. And so it's kind of, it's a scary thing to jump into something new and quite frankly complex, like fitting scleral lenses. But I'll tell you that it is the most rewarding thing that you can possibly do in practice as an optometrist. You know, you take patients from a very bad quality of life with whatever condition they have, the ones that Mile mentioned, and you take them to the limit of what their eye can do. And routinely you'll get patients crying in the chair. And these are not, tears of anguish. These are tears of joy. And when you see that day in and day out, I mean, you kind of get numb to it. But I love it when my students and my techs and my associate doctors see that, because you really are changing lives with scleral lenses.
And Jeff, one thing I would just add to that, as you start becoming more comfortable with this and as you start doing it more frequently, I would really tout the fact that consistency is king with this. Create that process in your practice and make sure you set up systems within your practice that facilitate the consistency of those processes. Jeff and I, we talk about these 6 scans that we take. That's not sometimes, that's not when we're troubleshooting, that's every single time we see the patient, because we feel that these measurements are that important to really create the best fit and best visual outcome for those patients. So again, make sure that as you get more comfortable with this, you are creating those patterns in your practice that create consistent care for these specialty lens patients.
Great. Well, Mile, Jeff, thank you so much for doing this tonight. And for everyone who wants to see a demo of the tech in action, if you go to visionix.com/ODwire, you can see it up there on the screen. You can get a great demo right online, and an archive of this webinar is going to be posted up on ODwire within the next couple of days, so definitely head on over there. You'll get an email about it, and you can ask follow-up questions there as well. So again, thanks to our speakers, and thank you everyone for showing up tonight, and I guess I'll see you again online.